to our Fall Prevention Learning Network webinar. I'm really happy that you were all able to join us. I know it's very close to the holidays, and many people are probably going to be away, but I think we have a really great presentation lined up today, and I hope that you'll all enjoy this and learn something new today. So just quickly, today's topics, just quickly go over some housekeeping items. I do want to spend a minute or two talking about our upcoming webinar schedule, and then we'll dive right into our feature presentation. We have Susan Mascioli, sorry for butchering your name, Susan. Susan Mascioli from Christiana Healthcare System, who's going to be sharing about their fall prevention activities that they have done at their institute. So really looking forward to hearing that presentation. I think we can all learn a little bit from what she has to tell us. So just a real quick reminder, we do want to reserve just a little bit of time at the very end for questions that you may have of Susan. So please use your hand feature to let us know if you have a question, or simply chime in. If you don't want to speak, please feel free to chat that question or comment to us. As always, definitely keep the background noise to a minimum. Please mute your phone so we don't hear any, the hustle and bustle of your hospitals in the background. And just make sure to unmute yourself when we get to the questions, if you have a question or comment. Just real briefly, in terms of the upcoming webinar schedule, beginning in January, we're turning the webinar presentations back to our participating hospitals, and you can see the schedule for the next 3 months on this slide. We have Good Samaritan and Good Shepherd, who are going to be presenting January. And again, these presentations are really for you. Nothing, they're not too terribly complicated. All we're looking for is to have the hospital share on 3 things that they feel they're doing now or that they're doing better now to improve the care that they provide to patients since they started this AHRQ initiative, as well as your plans for your fall prevention team after this AHRQ program ends, and then also any barriers or challenges that you're currently dealing with or that you anticipate dealing with for your fall prevention activities going forward. So we're looking forward to hearing from you all again. With that, I'd like to turn the presentation over to Susan, who will share with us about her research. So Susan, I'm making you the presenter. Have control.
Okay. Thank you, Michelle, and thanks for the opportunity for allowing me to share with you some of what we learned in our fall prevention improvement project, where we utilize Lean Six Sigma to really take a look at our fall prevention practices. I can tell you off the bat, and I know that you're all in a PI project with fall reduction, there is really no one easy solution to prevent all falls. But what I hope to share with you today is some lessons learned that we were able to uncover when we utilized the Lean Six Sigma methodology, and also to share with you some successful fall prevention strategies that you may find helpful. Just a little bit of background about our fall prevention program at Christiana Care. We have had a system-wide fall prevention team in place for quite some time now. The team is an interdisciplinary team, and it addresses fall prevention interventions and strategies from a system perspective. In 2011 and 2012, we did an organizational assessment of our fall prevention program that we were able to identify some gaps based on best practice recommendations, and we implemented strategies to address those gaps. An example of a gap would be medications that put a patient at high risk for falling. We necessarily have some strong interventions related to the medications, which we were able to implement. We also have an organizational and unit-based improvement effort reduce falls and fall-related injuries. Reducing fall-related injuries is part of our annual operating plan for our organization because we do focus on reducing patient harm. So it's a very high-profile strategic prevention effort for our organization. Having all that in place and despite all of those efforts, we still had challenges in reducing patient falls on 3 patient care units. And these units were medical surgical patients where we saw complex medical patients or even our stroke patients. So typically, the patients that would be more challenging to prevent patient falls on. So we decided to implement a new strategy, and that was a Lean Six Sigma project, where we took a deep dive into patient falls. We utilized the D.M.A.I.C methodology, which is the Lean Six Sigma methodology, and I'll go through a little bit. It's not really that different from PDCA. Probably the biggest difference is the use of research, so scientific rigor to the process. But what we did was we really wanted to look at improving our fall outcomes, reducing falls, reducing fall-related injuries by trying to reduce process variation, which becomes a very important part of any fall prevention program. So on our 3 units that we had, they were 3 medical units, our baseline fall rate for an entire year was 4.8. The benchmark was 3.4, so well above the benchmark of falls that we want for patient days. So we came up with a goal to reduce the combined fall rate on those 3 patient care units by 30%. So we wanted to take that baseline of 4.8 down to 3.4 in the course of about a year. So it was a pretty aggressive goal, but we were determined to be able to achieve that goal. So I think, I'm sure that you all have goals. I think it's really important to establish a timeline and a goal with any project to measure that along the way. So here's our baseline data. You can see from the graph that we were well above the benchmark most of the year. Our baseline, like I said, was 4.8, but a lot of variation. The fall rate ranged from anywhere from 0.3 up to 6.5, which was too high, and we really knew that we needed to do something different to reduce that rate and keep it sustained and low. So one thing that you do in your Lean Six Sigma work is to look at the financial impact of any of your projects. So we call that the business case or cost of poor quality, which is really what is the cost of poor quality, which in fall prevention is a fall or a fall-related injury. So we're able to find a good article where we used as a reference. Falls without major injury had a cost associated of $3,500. And we did learn through this work that it is sometimes not apparent when a patient falls the degree of injury that they have. It could be that nothing real obvious, such as a fracture, but they could need physical therapy or something could come up a week later. So there's a lot of things associated with falls and costs that are not apparent sometimes at the time of the fall. And in fall-related injuries, a major injury costing $47,000. So during our baseline year, we had 122 falls. So if you take the cost of $3,500 and add the cost of the major injury, that's a cost impact to the healthcare system or patients' insurance of $450,000. So pretty significant. The thing we wanted to do was we wanted to quantify what it really meant for nursing. Again, the cost of poor quality. So time spent taking care of a patient, doing an investigation of the fall, doing follow-up. We have a post-fall protocol here where we have to do neurologic monitoring, vital sign monitoring. Some patients require diagnostic testing. So we had participants in our Lean Six Sigma program actually collect data and look at how long it actually took to care for the patient in staff nurse time, in manager time, in physician time. So then calculating that time, over 6 hours falls without injury and 11 hours with the falls with injury, that's a lot of time. You can see the total at the bottom of the slide, over 750 hours of time to care for patients who fell. So reducing the number of falls will reduce that amount of time. So, if you say to a nurse, we can give you back time, here's some opportunity. So we utilized a lot of process analysis tools in our Lean Six Sigma work that we did. One of the things that we did was high-level process mapping through the use of a COPQ. And one of the key features of the COPQ, other than to identify the steps in the process, is to identify the key stakeholders. And with those key stakeholders, we did a tool that we call the Voice of the Customer, which I absolutely love and utilize it on a lot of performance improvement projects. And that is actually an informal interview or questioning of the key stakeholders. And in fall prevention, you can think of nurses, techs, pharmacists, physicians, providers, and just ask them, in our fall prevention patient safety work, what is working, what is not working, what is burdensome, what do you need to improve patient fall safety? Because they're the kind of things that when you're implementing your strategies, if your staff and key stakeholders are saying these are important, they're the things that we want to include in our fall prevention interventions. So here's a summary of some of the key things that we heard. First of all, the nurses feeling that all staff are not accountable for making sure that fall prevention strategies are in place. The nurses felt a lot of accountability and responsibility for falls, yet it really is not just nursing, it's a shared ownership. Everyone taking care of the patient really owns a piece in the patient outcomes. Physicians and the pharmacists really weren't sure the degree of patient risk or really what they could do related to reducing the patient's risk. Probably one of the most significant things that we heard, and it was a big aha moment for us, because we do identify patients at fall risk on admission. We put a yellow band on their wrist. We hang a banner in the room outside the door that says fall risk. So despite that and talking to the patient about falls, we had patients say that we don't think we're at risk for falling. And I'm going to talk about that a little bit more as we get into the presentation a little bit more. In the measure phase, I think it's really important. This is one thing that I think can be done as a baseline, but also ongoing, and that is to analyze your data from your falls. There are a lot of assumptions made about the trends and profile of the patient that's falling. And I think it's really important to evaluate the data because there were a lot of surprises that the team learned in some of the data that was presented. So 80% of our falls, there was really no apparent injury, but when you look at the literature, it really speaks to as high as 30% mortality rate post-fall, especially in the elderly patient population. So, any single fall can be a life-changing event for a patient, increased length of stay, loss of independence, and for some, it can be the inability for them to return to their home. So, really important work in reducing patient falls. So, falls by shift. Again, there was a little surprise in this. We thought that our fall rate was highest during the day, but really it was during evening shift. And I'm going to get into some data on falls by hour of day in a minute and talk about that. We had more males than females fall. And our patient population, of course, we always think that the real elderly patient population or the average age range for falls, but it really wasn't. It was the 55 to 69 group. So the things that we talked about in our team is this patient population a group that we don't necessarily think that they're going to fall, and they don't, where we worry a lot more about the elderly. There's probably no surprise in these data trends. You probably have seen this in literature, and you probably see the same in your own data when you look at it. A lot of issues around contributing factors with altered mobility, elimination needs and the need for toileting, a lot of patients being off balance, And we also were able to identify that the majority of patients were falling in their rooms, so not assisted falls with staff, and when they were getting in and out of bed. So one of the things that we really knew that we needed to address was the patients getting up unattended for most of the time with alternate status that were going for toileting. We look at falls by hour of a day on each of the units, and there were some interesting trends. 40% of our falls occurred during 7 hours of the day, and a big percentage during shift change. And we had between 5 and 7 in the morning and 3 and 4 in the afternoon, a large number of patient falls. So we knew that we needed to do some work around shift change, and we're able to identify certain hours of the day where there were issues related to an increase in patient falls. So we took each of the units, and we were able to look at their falls by hour a day. So this is number of falls by hour of day. If you look at unit number 1 and unit number 3, between 1,500 and 1,600, they had the largest number of falls. So for those units, when we saw this data, they implemented what we call just do it strategy, and that was they looked at what was happening on the unit when those falls were occurring, and they were able to identify that it was during shift change for the nurses, and the techs were in the rooms taking vital signs. So there was really nobody out, answering call bells and addressing patient needs. So they actually changed the time that they did the vital signs, which did impact the number of falls, and they were able to see a reduction in that. And then if you look at unit number 2, the majority of their falls were happening around shift change at the end of the evening shift. So again, looking at what's happening on your unit when you have a high number of falls and saying, what can we do differently? How do we meet patient needs to try to proactively address whatever needs they have to reduce the risk of them falling. So this was a really important part of the project that was able to give us some really good information on what was happening. We do patients' risk assessment, and we use what's the SMID score. I know there's a lot of different risk assessment tools out there. The SMID is mobility, mentation, elimination, fall history, and current medications. And again, an assumption that all of our patients that were falling, or a large number, were at high risk for falling. The SMID is a scale of 0 to 6, 6 being the highest risk, 0 being no risk. And this is the graph of the 122 falls from our baseline, and you can actually see that we had as many patients falling that were low risk, that were high risk. So the highest number was 3, but pretty much a bell-shaped curve. So we had in the past where we worried about patients that were fall risk of 3 or above, but we really needed to shift how we were thinking about falls, because we were having patients that were falling that we were considered really low risk, which I think I'll get into a little bit more, as one of our root causes of patient falls. So really important to understand your data and what's happening with it, because it really makes you start thinking about what interventions are important. We did do some detailed process mapping, and some of the lessons learned that we did identify during that time was the full risk assessment was not necessarily used to determine the level of risk. Nurse assessment really was driving the risk. So even though we were doing the full risk assessment, we're just making the assumption based on our assessment that the patient was at risk. And then what was happening is all available interventions were implemented. So we had overutilization that really wasn't targeted at risk, because what we heard from the staff was that they were unsure what strategy would really work. So they were just implementing everything, because I'm sure you know it's a huge issue when a patient falls. The staff feels upset, the patients and the families are upset. So the staff were just doing everything they could to prevent falls. And then if a patient was reassessed and there was increased risk, there was really no new fall prevention interventions, nor was it clear what was already done. So we knew that we needed to do a little bit of work around targeting the risk a little bit better than we were doing. Did try to get to the root causes of patient falls, and we came up with the top 5s. We utilized a process, we used 5 whys. And the number one that heard, and we heard this with the voice of the customer, is that all staff really were not accountable to fall prevention plan of care. And when we really got down to the 5 whys, what we heard from the staff is, though, that even though we identify the patient at risk for falling, we communicate, we implement a plan of care, really are surprised when they fall. We've heard this with falls with major injury. I really didn't think they would get up. They put the call bell on every time, and this was just one time. So when you have an assumption that the patient's either at little or no risk for falling, that was determined to be a root cause. We also had issues around toileting, not necessarily being proactive, and ineffective purposeful rounding. The staff perceived that they're already in the room. So why do I need to go in every hour? I'm already there. And they were concerned about staffing. How am I going to do that? I'm already busy. And the benefit of proactive rounding, because they felt like they were already addressing that, was really not perceived by the staff. Again, the patient, family, and visitor not perceiving themselves at risk. We really got to the root cause of that, is it being the optimism bias. We actually shared an article with our team members about how human nature is just to be more positive. So patients are not assuming a bad thing's going to happen to them, like a fall. So they really become more risk takers if they're not thinking that they're a fall risk and they have risk of getting injured. So kind of changed the conversation that we had with the patient about the risk. And then challenging patient types, we really felt like we didn't have the ability to flex the plan of care and staffing to meet challenging patient types. Patients change condition frequently, and again, just trying to implement everything we could to prevent patient falls. We really didn't have a plan for flexing that once the patient's condition changed. So these were what we came to, the top 5 root causes that we knew we needed to address in our improvement strategies. We did do some process theory testing, and I talked about the patients not perceiving themselves at risk for falls. So we actually interviewed patients, and we asked them, what do you think you're at risk for falling? And these are patients. Some of these patients were on walkers, were unsteady, and almost 85% of patients said no, that they did not think they were at risk of falling. And again, this was a big aha moment for our team and for the staff. And when we asked the patient why they didn't think they were at risk for falling, they said, because we trust you. Then they're taking such good care of me. So again, I think this was a really big thing that we identified, and we knew that we needed to partner with our patients and families a little bit more strongly in all of our strategies that we improved to really get them to appreciate their fall risk. We looked at medications, and we wanted to know what % of medications were high risk that were involved in a patient that fell. So nearly 80% of the patients that fell received at least one high-risk medication prior to the fall, which was pretty significant, higher than what we thought it would be. And when we looked at what those medication classes were, they were antidepressants, antipsychotics, and anticonvulsants, making up 88%. So when you look at those types of medications, they are not necessarily medications that we can modify sometimes. So, how do we work around that, knowing that we may not be able to change them? And antidepressants accounted for the largest number, 37.1%. So again, may or may not be able to change the patient's medication, so we needed to strategize around that. We also looked at rounding. We had implemented purposeful rounding many years ago, and we wanted to see how we were doing with it because, when we look at the literature, going back to the Studer literature, the effectiveness of rounding with reducing patient falls. So we found that there was variation in how rounds were actually addressed. When we looked at the 5 Ps, nearly 20% had all 5 Ps addressed every single time. So rounding was not always purposeful, and it wasn't always addressing the defined topics. And I think this is a really important lesson and a take-home, that even though we think we're doing what we should to reduce patient falls, we're probably not doing it as well as we could if we're not having the outcomes they want. So when we looked at how was being addressed, we actually collected data, we did observations, and about a third of the time it was proactive, meaning you went to the patient, let me take you to the bathroom, let me address this. A third of the time it was patient initiated, so the patient would say, need to use the bathroom, or a third of the time we asked a question. So it wasn't proactive, it was, do you have to utilize the bathroom? So really not hitting the intent of being proactive 100% of the time. And when we looked at what 5 Ps were addressed, toiling was addressed almost 78% of the time, but then you can see that there was a decrease. And, positioning was probably the less, 36% of the time, and pain, comfort, and then the environment addressed 50 to 60% of the time. So while we thought that we were doing rounds, again, not necessarily proactive, not necessarily addressing all the 5 Ps. So really important when you implement a strategy to measure the process. So it becomes culture, so that you know that what you're implementing is actually effective, or if it's not, you need a different strategy. Other things that we learned during our theory testing was fall prevention strategies were not always aligned with risk. And I talked about that a little bit already. We were just, implementing everything that we could think of, not necessarily targeting like a mobility risk or orientation risk. The plan of care was not consistently communicated with staff, and most importantly with the patient. We would talk about that they were fall risk, and as I said, we would put a band on their arm saying fall risk. We didn't continue that conversation over and over again so that it actually resonated with the patients, which became a strategy that we implemented. For our stroke patient population, while we have a mobility assessment, it was not really well understood or documented, so we knew we needed to do some work around that. And then the things that we also tested, and we didn't know if they were factors in our falls, were unnecessary IVs, urinary tract infections, and C. difficile infection did not increase the risk of patient falls in a patient population. We actually looked at that, and they were not factors that we were able to identify. Then we wanted to move into strategies or solutions to prevent patient falls, and build into every single solution. We wanted to, one, actively partner with the patients and the families in all of the solutions, because we knew that engaging them in fall prevention was going to be something that we knew we needed to do because we weren't effectively doing it, and we wanted to hopefully partner with them to help reach their risk. It's to build accountability into the plan of care, so meaning that all staff are accountable. We display data prominently on the units for the number of patients that fall, so that all the providers are aware of the falls on the units, as well as the nursing staff. We did align the fall risk with specific interventions. So in our electronic medical record, when the nurses are actually scoring the patient risk as they move through all the categories, there are now interventions aligned up with that risk. So if they are, the mentation is what they're scoring, if the patient scores that they are at risk because of mentation, then a strategy for mentation, such as, putting the patient close to the nurse's station or a low bed or whatever it may be, was actually aligned up with that specific risk. So we wanted to make sure that we were getting the right interventions for the right risk. We implemented a strategy for verbal communication of fall risk at every single handoff. So we do bedside shift report, Anna, and every single shift report, the fall risk and the fall prevention plan of care was discussed between the nurses and the patient. And that really started to shift the patient's thought process around patient falls, because remember I talked about 84% of our patients did not think they were at risk for falling. As we started to talk about this 3 times a day at change of shift, or 2 times a day, no matter when we had shift change, the patients started to say, well, I didn't think I was at fall risk, but I'm being told I am, so I need to put on the call bell because I am at risk for falling. So over and over again, repeating that risk to the patient really started to resonate. Patient-centered early rounding, we implemented, we changed the focus of it a little bit to engage the patient in, and I'll talk about that in a minute. And then we did a mobility assessment strategy on our stroke unit because we knew that patients had a lot of issues with mobility, and we wanted to make sure that they were also engaged in the strategy. So we were actively telling them what we were doing, why we were doing it, and we actually had an algorithm for how they could ambulate based on that they were at risk for falling. And then we would communicate that mobility assessment and how the patients could ambulate to not only the patient, but also to the rest of the staff. So for our implementation plan, there were key features of the implementation plan for all strategies. Again, we had staff accountability, and that was interdisciplinary. We communicated the plan to all key stakeholders. So there was a communication plan to providers, physicians who came on the unit, to patient escort, to the nursing staff. So it was much more broad than nursing. We had visual controls. We had pocket cards. We had laminated keys that we had throughout the unit so that people had information that they needed for the strategies in their workflow. And then probably the most important thing that we did, and this is, I think, a very important thing, not just to do for fall prevention project, but for any project, and that is ongoing process monitoring. So if you implement a strategy, it's to be a measure of how you're doing with that process, and that needs to be sustained over time, and I'll talk a little bit more about that as we go on. Some of our tools that we implemented, we actually did scripting. This is our handoff communication tool, so this is scripting for the bedside shift report. So we actually crafted the wording that we wanted to communicate to the patients, and we also started to tell them not only about the risk for falling, but the risk for injury and what that potentially could impact, in their abilities going forward. And then we also communicated what we're doing to improve their safety, and that was communicated to them every shift. So reinforcement of the fall prevention plan of care, actively engaging the patient in that conversation, and this is actually a picture of the pocket card that the staff would carry around so that they had it with them and they could utilize this and communicate the same message over and over again. We also had a patient-centered hourly rounding tool that we utilized, and again, it has really specific scripting on it so that it was more engaging with the patient and also more proactive, so that we didn't kind of go back to that, asking a question or let the patient initiate. It was much more proactive and addressed all 5 of the Ps. And there's an example of a pocket card that the staff actually carried with them so that they had it with them at all times and could utilize it. And then for the mobility assessment, like you can see at the top, there's actually scripting. I'm going to do complete your mobility assessment. And this was a collaborative effort with the physical therapy department, and we actually developed this algorithm where the patient's ability limitations were actually documented and how the patient should mobilize. And the staff were given the reference, and we laminated the process and mounted it on the units. So not only did we implement the strategy, but we gave the staff tools and had tools available throughout the unit so that they would be readily available. And as I said, I think one of the most important pieces of the fall prevention project was the control plan. So the control plan is the ongoing process monitoring so that we make sure that whatever strategy we implement, we are 100% client or 95% client, whatever that threshold compliance may be with the process. Because what we find is that we educate staff, we roll things out, and we're not always 100% or 90% compliant with what we said, and then we still have the problem, and we assume the strategy didn't work. So it may not be the strategy that didn't work, it may be the process that really wasn't implemented and sustained like we wanted. So in order to make sure that we continued to have success, we not only implemented the process monitoring, but we also established thresholds for what we would accept for the number of falls. And if we go over that threshold, with compliance monitoring, if we met compliance, meaning that, let's say, if we rolled out purposeful rounding and we said 95% of the time we're going to be compliant with proactive rounding and all 5 Ps need to be addressed, if we were compliant with that and we were over 95%, then we need to say, okay, that strategy isn't really helping us as much as we had hoped. We need to consider additional fall prevention reduction strategies. If our compliance was not met, and let's say we were only 80% compliant, then we needed to re-educate and increase monitoring. So our monitoring outcomes really drove how much we needed to do from a process monitoring standpoint. So I do think that a very strong control plan of whatever you put in place is a key is a really key thing that you need to make sure you have in place to maintain success. So once we implemented everything, we wanted to see if we could have a sustained reduction, and we wanted to know what else was affecting our fall prevention strategies and the success of it. Was it a culture of accountability? Was it staff buy-in? Because we always seem to have, when we focus on something, we seem to be able to achieve a goal. But we wanted to study that a little more. Is it front-of-mind awareness about fall risk among all staff? And so what we decided to do is with 3 units in this fall prevention project, we took 3 other like units and we matched them. And the units that were not engaged at all in the D.M.A.I.C process or the Lean Six Sigma that we work that we did. So when we matched the units, they were really different. They were not engaged in the strategies. They did not conduct any process monitoring. They were implementing all the rest of the fall prevention interventions that the rest of the organization did. We didn't give them any kind of feedback about current practice. We simply just implemented the strategies. And I think this was a really good strategy for us to do, because what we wanted to do was we wanted to see if we just rolled out the strategy, would we be as successful on the units that were not engaged in the project as ones that were, and really make a difference. And I think one of the things that this really made us think about was think of all the things that we just implement, educate, and move on, and assume and hope that we have the success that we want. So we actually were able to look at, we have this, if you look at this slide, the D.M.A.I.C units are the units that were involved in the project, and the non-D.M.A.I.C units were the matched units that we just implemented the strategy. So for hourly rounding, we had on one of the units, we had a baseline fall rate of 3.9, and then had a fall reduction to 1.3. When we rolled out the same strategy, hourly rounding, we had a baseline of 2.6, and during the pilot phase, we only saw a 0.1% reduction, so not nearly as significant as the units that are involved in the project. We saw the same for the handoff communication strategy. We actually didn't see any improvement. In fact, the fall rate went up on the unit that was not involved in the project. And then for our ability assessment strategy, we had significant reduction in falls on the unit that was involved in the project, but very, very small reduction on the units that were only implementing the strategies that were not part of the project. So what these results suggest, we're kind of surprised at the difference, but we would argue that where there's leadership and frontline staff that are actively involved in the design of the work, shared decision making, owning the project, establishing unit champions, that all three strategies significantly reduced inpatient falls. Without that, strategies really were as effective. Again, I think it's something to think about when you move forward in implementing strategies, really garnering the engagement of the staff and having maybe not necessarily a whole PI project, but figuring out how you get engagement to try to change that culture, because without it, it may not be as successful. At least that's what we found. We wanted to see, okay, we had three strategies that were successful, but did they all work and were they all sustainable? So again, all three of them were a success, but then we analyzed data 8 months later to really figure out what was the most lasting of all of these strategies. So again, looking at what is success and what is sustainability, because we really want our strategies to be sustained. So for hourly rounding, you can see that our baseline to our intervention, we had a pretty significant, a statistically significant reduction in patient falls that was sustained. So our rate over time actually stayed below the baseline. For handoff communication, we did have a reduction, but it wasn't as sustained. And then same with mobility, a little bit of variation. So what we found was patient-centered hourly rounding was really the best strategy for long-term sustainment of fall reduction. So a really good strategy. We do not feel that it would have been as effective if we did not have a strong control plan, making sure that all the different process measures in hourly rounding were actually conducted. For spread, we implemented patient-centered hourly rounding system-wide with focus on what we learned. We knew we needed staff engagement. We couldn't just implement without having unit champions, leadership's engagement and partnership with the frontline staff, and a culture of accountability, meaning that everyone is accountable, and the outcome of falls was really a shared ownership. We were able to propose a framework, which we actually published in Nursing 2014, and that was there really should be three components of any fall prevention approach. Number one, really understanding your data, being able to understand what is happening on the units by analyzing the data and removing those barriers to compliance. Understand that, you know, if you've implemented hourly rounding, that you're compliant with that. Number two, active partnership with patients and families. It was a successful strategy in all of our areas, and we really felt like we got the patients and the families really changed the way they thought about fall risk, and which we felt was helpful. And establishing a culture of accountability of all staff. So, you know, staff needs to not only hold themselves accountable and each other, but to the fall prevention plan of care. So something that people can think about when they are implementing any kind of fall prevention program. So there's our data over time. This is 5 years worth of data. The baseline was 2012, so you can see it's a downward trend. We were able to meet our goal of 3.4, and while there is a little bit of variation overall, fall, when we look at it annually, is well below the 3.4 benchmark or baseline that we actually established as our goal. So we felt like this was a successful project and learned a lot through the Lean Six Sigma work. And again, the thing to realize about the work that we did here is these were the most challenging units that we had from a fall prevention standpoint. Some of our lessons learned, the individual and unit accountability for fall prevention is critical. There really needs to be buy-in, not only staff, but patient and family engagement in fall prevention is key. We know if a patient does not appreciate their risk, they become a risk taker. So we felt like that engagement was really critical in every strategy that we implemented. Trends need to be analyzed for improvement opportunities. You could do an improvement project on falls on 2 different units, and your data can tell you 2 different things. So that data is actually going to give you a lot of really good information about where you need to focus your energy as far as your interventions for improvement. Vulnerable process points need to be identified and addressed. Handoffs are critical. One of the things that I didn't mention that we were able to identify is we did a really good nurse-to-nurse handoff for fall prevention, but not so good handoff between nurse and techs. So we actually were able to implement and tighten up the handoff between techs so that everybody really understood the patient's fall risk. The top 5 causes and root causes of all patient falls need to occur. So really getting to what is actually happening as a root cause will really help to address the appropriate strategies. All staff need to be actively engaged in performance improvement. We learned that if we just try to implement a strategy without all staff being engaged, it's not as successful. So that is a really critical and probably the most important part of the lessons learned in this project was to monitor compliance and be prepared and strategize for drift. So over time, we do know that sometimes there is drift, and we could be 100% compliant with successful rounding, and then over time, that seems to decrease. So having a control plan where we will increase or decrease monitoring of the process based on the outcome of patient falls, I think, is really critical. And then lastly, the Lean Six Sigma project, we felt like gave us a real in-depth analysis of workflow and the process, and we had some really significant lessons learned that we thought not only helped us in this project, but also helped us with process improvement in general, looking at outcomes and sustainment. I think one of the big takeaways that we had was the ongoing process monitoring to really drive outcomes. And we utilize that in other things now here, for example, with CLAP, see how well are we doing with site care and other interventions, because that is the most important thing. If those processes that we're implementing to improve are in place and 100% of the time, if that's the correct strategy, we're going to have better outcomes to the patient. A couple references. One is the article that I talked about with the framework for patient falls, and the other is the cost of poor quality, a really good reference article on looking at the impact of patient falls to the healthcare system and also to the patient. That's it. I think I can open this up to questions now.
All right. Thank you so much, Susan. That was a really great presentation. It was really fascinating to hear your process and how you approach this and your results. So, yes, we do have 10 minutes for questions. So I'd like to allow anyone who has a question to okay, I see Kelly, you have a question. Make sure you're off mute, Kelly.
Hi, everyone. This is Kelly O'Neill with Stratus Health, and I would like to thank you for an excellent presentation. You've done some great work, and congratulations on your success. I have a question. I'm sure I just missed this, but when I look at slides 43, 44, and 45, which shows your data, looking at falls rates by the focus on hourly rounding, communication and handoff, or mobility assessment. So was that the main focus of what 3 units did, or were these the same unit? I just got a little confused as to how you were able to pull those specifically out and look at them separately.
Yes, that's a great question. So we implemented them on different units. We implemented the mobility assessment on our stroke unit. We implemented handoff communication on our unit that through looking at the measured data, we identified that we had issues with handoffs. And then the hourly rounding we implemented on the 3rd unit. We ended up implementing purposeful hourly rounding across the whole organization when we identified that that was the most significant improvement, and we knew that we needed to spread that and had sustainability. So they were implemented initially on all 3 units, different strategies.
Okay, I'm sure you said that. Thank you so much. Wow, those results then are just really, really helpful, I think, when you see the impact of rounding.
Yes.
Absolutely. Actually, I had a question about rounding and also with information about your interventions that you implemented. I'll come back to that because I see there's a hand up. We have Marianne Douglas who has a question. So, Marianne, can you make sure that you are not muted? I'm sorry, it looks like it's a question that was submitted. So she asked if you could provide the name of the article, Human Nature, Patients' Lack of Recognition of Fall Risk. Is that one of the references that were included?
Optimism bias. The article that we read about human nature having the optimism bias and that they don't think that they're actually going to get hurt or bad things happen to them. Is that the question?
Yeah, I think she wanted to know the article regarding how patients lack of recognition of their fall risk. So if that's a reference that you can provide, that would be great. She's not on the telephone. That's why she's unable to ask the question. She's just listening through the computer.
Yep.
Well, great. I wanted to just follow up on those questions. So you just noted that the patient-centered hourly rounding was something that you at least initially tried in one of the units, mobility assessment, and then was it the verbal communication of fall risk at handoff was the other intervention? Okay, so the alignment of fall risks with specific interventions, was that something that was rolled out hospital-wide?
Rolled out hospital-wide, yes.
Okay. So you weren't necessarily, or were you able to discern the impact of that relative to the hourly rounding?
Because what we did here and what we saw when we did our, did like process mapping, analyzed practice, that the staff were not aligning the risk with the specific intervention targeted at that risk. That was across the board on all 3 units, so we just implemented that strategy organization-wide.
Right. Which, and in fact, in our current effort, our experts really press that is one of the most important elements of, addressing fall risk. Now, I found it also interesting that your patient-centered rounding was so effective. One thing I wanted to ask about that is, with your patient-centered hourly rounding, is that on all patients, or do you target the rounding to those patients who are at the highest risk?
No, it's on all patients.
Okay.
During the day, every 2 hours at night.
Right.
So I have a question.
Sure, go Barb.
Hi, Susan. This is Barbara Ebel.
Hi, Barbara.
Hi. Our hospitals have had pushback from their nursing staff. They did scripting. And I noticed that you did scripting on almost all of your interventions.
Yes.
I wondered if you had pushback from the staff who see themselves as individual practitioners, and how you dealt with that.
So we actually engaged the staff in developing the scripting. And I think that's another thing that helped us with this project, and that is really the engagement of the staff. So we just took the problem to them and said that, the communication and the messaging to the patient is variable, and the we need scripting and we need the message to be consistent, and we asked them to draft what they thought, and we tweaked it a little bit. But I think part of the success in that is asking them and engaging them and what the scripting should be. And then I think the other thing is, I think the scripting and the messaging and the success breeds more success. So I think the messaging to the patient over and over again, they knew that they needed to do that, and we actually gave them the tools based on what they recommended. So I think it's probably twofold. I think it's one, engaging them in what the scripting should be, and then two, showing them and engaging them in the process that was successful utilizing the scripting.
Good. I have one more question, if that's okay.
Sure.
You emphasized, and we emphasize so highly, right now we're in the sustainment phase, and we emphasize the piece and how you have to keep auditing to make sure your processes are working. Yep. I wonder if, since you have some experience of being several years out from the original implementation, how often you have asked them to audit, control, and any process where you do it quarterly or every other month or something like that.
So we have, over time, decreased the monitoring as long as the fall rate stayed under the threshold. Once the fall rate goes above the threshold, we increase monitoring. So I think coming up with a good plan for how often, I will tell you, it takes a long time to change culture, to hardwire the rounding where you're just doing it and you're not really thinking about it. So we monitored it daily when we first rolled this out, and we monitored it daily for months. And we only backed off when we knew that we were above a % compliance. So I think if you come up with a control plan with what you accept as an okay rate for compliance, whether it be like 90 or 95%, and then you come up with a plan for drift. So and that's why we established a threshold for fall. So if we're monitoring, weekly or every other week or monthly, and we're below those 2 falls for that unit for that month, then we're probably okay. When we go above those 2 falls, then we need to go back to the process monitoring and increase that monitoring. So we did that for a very long time until it just became more of a culture.
And one follow-up to that, many of the hospitals have limited resources, and of course they want the majority of their nursing resources to be focused on care. And for various reasons, they go through vacancies or reductions in force, et cetera. Did you have any unique ways of building that into the process to make it easier and less resource-intensive?
Well, we utilized some of the educators to do some of the monitoring. We utilized our quality and safety councils to do some of the monitoring. I totally get the staffing thing. We hear that a lot. don't know if there's a really good answer. We tried to, at one point we utilized students. We had interns in the summer. We had them do some of the monitoring. So we have light duty nurses doing some of the monitoring. So I think it's just a matter of trying to figure out, how best to do it in the less intrusive way to get data. So we used a lot of different ways to do it.
Thank you.
Great. I have a question for you, too. This comes from Marion Douglas, and she sent it in through the Q&A. First of all, she did tell you that it was a very, very good presentation and very timely with other training that she's going through. But her question specifically was, how is purposeful rounding tracked to ensure that it's being done? Or at least how are you doing that at your facility?
So we do require documentation of rounding. There's a lot of communication about whether that is the right thing to do or not. I think the most important thing to do is to communicate when the rounding was done, so that if another member of the healthcare team came in. So we have these whiteboards in our rooms, and we have rounding at the bottom, so you can see actually when it was done, a check. We do require documentation. There's one at that. I'm here to say I'm not sure that that's necessarily, the best strategy. I think the best strategy is to make it obvious when last rounding was done, so that anybody who responds to the patient knows if rounding is required or what was done when. So I don't know if that helps, but that's different than the monitoring.
Okay.
Does that answer the question?
Well, I think so. So, Marianne, if you have a follow-on question, please feel free to submit it. If there are any other questions, I know we have reached the top of the hour, but I think if you have any additional questions, Susan, I'm sure, would be happy to take them.
Brenda from Good Sam, can I just make a comment? I think one just quickly, this is a very, very good program. Thank you very, very much. I just have two comments about the people monitoring. One, you talked about accountability at the beginning, so I think that what we've done here at Good Sam and we have established that the managers do it just to link it to the accountability. And I do question, a thought about having all of the different data collections. How do you ensure interrelated reliability and consistency of data if we have too many different data collectors?
Yeah, so it's not research. It's yeah, right. We did do some research on this, but it's not research. And I think in the spirit of performance improvement, we set up the tool as best we could, made it as simple as possible, and did training on the tool, and hope that the data collection is consistent, across. But we're more worried about are they documenting what they're seeing, and are we getting the right data, and less worried about the integrator reliability for performance improvement.
People. I do think it's important to consider that the managers be accountable for their
Absolutely, and that was a big piece of the leadership buy-in and accountability, and also as nurses holding each other accountable. It's not really acceptable to not do something that you should be doing, right? To hold each other accountable. But I totally agree with you that the leadership buy-in and accountability and holding others accountable is absolutely key.
As a follow-on to that, Susan, how do you implement or operationalize accountability at the staff level? What does it look like?
I think that's a bigger safety. I think that's a bigger patient safety question than what we do for rounds. So, is it perfect what we do here? No. But we do bedside shift report where nurse to nurse you are turning over a patient that you have certain things you're supposed to be accountable for, and if you're not completing them or have not done them, then you're accountable to that next nurse. So I think it's more of a culture of I'm accountable to my job, but I'm also accountable to you in getting things done that I have gotten done. And, the conversation changes to, was that done? Was the dressing changed? Why wasn't it? Okay, you're going to change that dressing before you, or whatever, you know what I mean? So
right.
I think that's probably a bigger question, peer-to-peer. But we have a lot of conversations about staff holding each other accountable because we all need to.
Right. All right, well, fabulous presentation. I don't see any other questions unless anyone else who's holding out would like to ask a final question. Well, if not, I want to thank Susan Mascioli for her brilliant presentation and the hard work that they've done in sharing all the lessons learned with our group of hospitals who are currently implementing fall prevention activities. And I want to thank everyone for attending so close to the holidays. I hope all have a wonderful holiday season, and we look forward to speaking with you again after the holiday and to hearing the presentations next month. So if you wouldn't mind, as you exit, please complete the webinar evaluation for us. It's very important information for driving improvement. So thank you, everyone, and thank you again, Susan.
To everyone in their improvement projects. I know fall reduction is not an easy thing to work on, so really best of luck, and hopefully you'll have some good success.
Well, thank you, everyone. The webinar is adjourned.